I'm Senator Carri Hicks, and I just wanted to talk about a package of bills that we filed in order to address the cost of care for diabetes in the state of Oklahoma. It's a really complicated issue, and so we know that we need to file multiple bills in order to bring down the cost for everyone. So we've got 7 different bills. 2 of them are on transparency, and really this is just acknowledging that there is a problem. It's not going to bring immediate price reduction or cost relief to individuals in Oklahoma, but sometimes the first step just is about acknowledging the increasing prices that are associated with needed medications and devices in order to manage this really complex chronic illness. We also have a copay cap bill. Ours in the state of Oklahoma that we're proposing really is kind of unique in that it's not just an insulin price cap, but it also looks at supplies. So for my son who has type 1 diabetes, he has a pump, he has a continuous glucose monitor, he needs insulin, he needs multiple things in order to manage this disease. And so knowing that capping insulin is a good first step, the supplies are really important to making sure that people get the best level of care possible. Another bill that is somewhat a first of its own would be acknowledging the standards of care and directing insurance companies to cover the cost of just a standard base level of care. A lot of times our healthcare providers will write a prescription because we know that the best medical treatment is preventive for long-term complications associated with diabetes. Unfortunately, then the insurance company gets to make a decision as to whether or not they'll cover the cost of that supply, and it's devastating to families when they can't have access to the medical treatment that they deserve. So our standards of care really looks at what is needed to manage this very complicated disease in order to really save money in the long run. It'll lower amputations, it'll lower retinal trauma for blindness, and it'll keep people working and active in the community when we give them the necessary medicine that they need. So as we were really trying to figure out exactly what's driving the cost of drug pricing across the board, one of the things that was really difficult is that you've got the manufacturer, you've got the PBM, the pharmacy, the insurance company. There's multiple pieces to this equation. And so we just want to make sure that if there's a rebate offered on a specific medicine, that passes directly through to the consumer so that they're not facing these insurmountable out-of-pocket costs all year long. I really wanted to also address non-medical switching. This is kind of a term that's used whenever there's an incentive or there's an offer somewhere kind of behind the scenes to get a lower price on something that might just be cents on the dollar, but what it causes is a disruption in the continuity of care for that individual. So if we're switching from Humalog to Novolog, which are 2 different types of insulin, ultimately that can cause a lot of disruption in the treatment for that individual, which can lead to days off work, higher A1C levels. And so in order to really make sure that everyone is getting the continuity of care that they need, we just want to take a closer look at what is considered non-medical switching, when is it necessary and beneficial to the patient, and when could it potentially have some detrimental side effects. So the federal guidance that came down from the IRS in 2019 really classified insulin as preventive therapy to mitigate long-term complications for individuals with diabetes. Unfortunately, it's not required, and so at this point it's just a decision, and we'd really like to see that be codified in the way that we know that it will lead to better outcomes long-term for individuals with diabetes to have insulin classified as preventive therapy.